Hello, so my name's Tony Hunter. I'm a Professor of Artificial Intelligence at the Department of Computer Science at University College London. So my research area is in computational models of arguments. I'm interested in how people can address complex situations by analysing arguments and counter-arguments, and we develop theoretical models and software for that. So the reason I came into this area was that a number of years ago Matt was interested in the use of argumentation in medicine, and this was an interesting topic both for us on the AI side, but I believe also on the medical side. So rather than say more now, I'll just enter straight into the talk and hopefully make some of these ideas clearer. So what I'd like to do is very briefly say something about computational models of arguments in my research area, then very, very briefly mention that there are some applications of this work in healthcare, and then I want to get onto the main part of the talk, which is the problem of evidence aggregation. In particular, talk about how we can use argumentation for aggregating evidence. So argumentation is an important cognitive process. Arguments are normally based on imperfect information, and so we see that humans deal with complex situations by constructing arguments and counter-arguments. So this can be information that's incomplete, inconsistent, uncertain, or subjective, and it can come from multiple sources. So I've just put up some very simple, diverse examples of arguments. So starting in this list, we've got mathematical arguments. So here we're working with something that's very correct and based on definitions, and so we can construct arguments from this and feel confident about the conclusions. But most arguments in real life are much more uncertain. So we have epistemic arguments where we're reasoning about the belief that we may have in certain piece of information. If we don't know something, we may conclude that that information doesn't exist. Scientific information, of course, we're all very familiar with how science is informing the development of knowledge and how we can use that scientific knowledge in arguments. And in the final example on the list is subjective knowledge, which is so important in medicine, but also in many other areas where, for example, here we've got a patient who has a preference, and this can be valuable information when constructing arguments and evaluating them for decision making. So in our community, we're developing various theoretical models for modelling argumentation. Here on this slide, we're looking at abstract argumentation, where we just deal with arguments as atomic entities. So if you look on the left, we've got graph 1. So let's suppose after the Cochrane, this meeting here at Cochrane, we're deciding to go back to my apartment for a party to celebrate a nice session. And so I say, let's take the metro home. So this is graph 1, and we know nothing else. There's no other arguments in play. So we could say, well, this argument wins somehow. Now, then supposing somebody comes into this room and says, well, there's a tube strike on, a metro strike on. So this argument attacks the original argument. So A2 attacks A1. So we're now in the second graph, graph 2 in the middle there. So graph 2, you can see A2 is now green, so it's an argument that we can accept, or it wins. And now A1, which originally in graph 1 was a winning argument, now loses because A2 attacks it. So this idea of winning arguments, losing arguments is the notion of dialectics that we've been formalizing as part of our theory of computation. Now graph 3 is interesting because we can extend the example. So somebody else has come into this room and said, well, A3, we've got most trains still running, which is a common situation when there's a strike on the metro. So we're now on graph 3 on the right-hand side. So A3, there's nothing affecting that, so that wins. Now, interestingly, A2, which was originally a winning argument in graph 2, now loses. And so you see I've used this red colour to denote that. Now, furthermore, what's interesting is that because A2 is now losing, we've got reinstatement of that original argument A1, so that wins now. And so this idea of dialectics is quite intuitive, and there's some very nice mathematics that goes underneath it that provides some justification for using it. So we're going to be using this idea of dialectics today. So here's the second example, another fictional example, here slightly more medical. So we've got A1 and A2 are two possible treatments that one could give for a patient who's got hypertension. So you see we've got here these arrows of attack. So A1 attacks A2 and A2 attacks A1. And this is because we've got this implicit integrity constraint that would say that if you're treating a particular disorder, you would only give one treatment for that disorder. So we can only give A1 or A2. So they attack each other. Now we've got, in addition, A3, which is a contraindication for one of these suggested treatments. So A3 is a contraindication for beta blockers, so that attacks A2. And so now we can evaluate this using this idea of dialectics again. So nothing is affecting A3, so this is winning, we can accept this. It attacks A2, so that's losing, so we don't accept that. And A1 is now reinstated again, and so we can accept that. So in this particular scenario, we can prescribe dialectics. So this is a very simplistic example of how one could possibly use argumentation. How we're going to be using it in a few moments is slightly different, so we'll get to that. So very briefly, there are other applications of argumentation in healthcare. So I've just listed a few examples of people and projects where argumentation is being used. The first two are from John Fox, who's now based at Oxford University, was at Cancer Research UK. And he's been a pioneer of the development of argumentation in healthcare, and so he's come up with various projects, including computer decision support for GP prescribing and tools for multidisciplinary meetings. And these have had substantial success, and there have been various trials to show their efficacy. Matt and I, together with colleagues, have been looking at various other areas. I won't go into the details of the third one is what we're going to be looking at in detail today. So what we're interested in today is the problems of dealing with primary evidence in evidence-based decision-making. So I'm sure you're all familiar with how evidence-based decision-making is based on primary evidence, and that clinicians have a problem of dealing with vast quantities of new results that are published every year. And furthermore, the evidence that's available in those trials and other results are often heterogeneous, uncertain, incomplete, and inconsistent. So these are real challenges. To help clinicians, of course, there are published aggregates, so things like systematic reviews from Cochrane and other organisations, guidelines from various organisations, and so on. And these can help with dealing with primary evidence. However, published aggregates are problematic for a number of reasons. They're expensive to produce, they take a long time to produce, they can quickly become out of date, they're for broad patient groups, normally with no other problems, they don't consider comorbidities normally. Often they use subjective or context-specific criteria to interpret the evidence, and these are often not made explicit. And finally, we feel that they decouple clinicians from the process, and so they feel somewhat excluded from the process of aggregating information, and they're unable to bring in their own context-specific information. To address these shortcomings, we felt there's a need to develop formal computational tools to help people aggregate information. And so we're interested in helping producers of aggregates, so people who are producing guidelines and systematic reviews. We want to help researchers who want to look at the current state of the art and identify new questions. And last but not least, we want to help clinicians. So what I'm going to do now for the next 10 minutes is speak about a running example. So this running example I'm going to use to illustrate our approach. So it's with fictitious data, but hopefully it's indicative of the kind of data one might expect. So here we've got a table. We call it an evidence table. It's like evidence tables you often see in guidelines and systematic reviews, but we expect it to be using particular terms. There's no free text, and this is the input to our method and to our implemented version of the method. So the computer can read these kinds of data. So each row is an item of evidence. We've got 2 treatments, so we've got a pairwise comparison between the pill and no treatment. We've got a column for the indicator that we're considering, so we're considering risk of pregnancy, risk of ovarian cancer, risk of breast cancer, and deep vein thrombosis. We have a column for risk ratio, but we could have other ways of measuring the outcome. Then we have a column for outcome. So this is an additional column, and this denotes excuse me, whether we regard the outcome as being I do apologise.
Can we just take over for a minute?
Could you?
Yeah, that's right. Well, we're
yeah.
both on thinking. So the outcome column, it rather simplistically tells us which outcome is better. So when we have a risk ratio, which of these is a good outcome? So just to take an example of that, if we look at E1, we've got the contraceptive pill versus no treatment, clearly reduces the risk of pregnancy, and in this context, therefore, that's a good risk ratio. Whereas if you look at E4, we have contraceptive pill versus no treatment, which slightly increases your risk of a deep vein thrombosis, and that's a bad outcome. And it's just worth saying, although that may seem very trivial, in fact, if you take away the outcome column, it's not clear whether having a reduced risk of something is a good thing or a bad thing. The computer can't know up front what ends we desire. And then the final column is the p-value, which of course you're all familiar with, and we're aware of the criticisms around use of p-value, but it's at least a useful place to start.
Okay, thank you very much. So the columns that we have, they're all compulsory in our method except for the last column. Often when we're using this method we have other columns, and I'll talk about that later. So all but the last column are compulsory. So what we do is we take the evidence, so this is the same table you saw on the previous slide, and we construct arguments. So these yellow boxes are arguments. So what you see there on the left-hand side column, we've got CP greater than NT. So these 3 on the left-hand side are arguments saying that the pill is better than no treatment. Furthermore, we have within the curly braces a set of evidence, or subset of the evidence. So E1, the first column in the table, is saying that the contraceptive pill is better than no treatment. And that's just taking into account the indicator pregnancy. The second argument on the left-hand side is also saying contraceptive pill is better than no treatment, but that's based on the ovarian cancer evidence. And the final one is taking both of those items of evidence together. Then on the right-hand side of the graph, we've got 3 arguments that say that contraceptive pill is inferior to no treatment. And so we've got E3 or E4 or E3 and E4 together that allow us to make that inductive claim. Then we've put in these arcs that denote attacks. So each argument on the left attacks each of the arguments on the right, and vice versa. So mathematically we've got a bipartite graph here. So this just denotes that the claims of these 2 arguments are conflicting. So where CP is greater than NT, that conflicts with CP being inferior to NT. Now what we want to do is break these attacks, symmetrical attacks. So that's what we'll come to next. And the way we do this is we have preferences over outcomes and their magnitude. So if you look at example 1, we've got, if we take the contraceptive pill, the benefit in this particular example, in example 1, is the relative risk of pregnancy is 0.01. So in other words, you've got substantially reduced risk of pregnancy if you take the contraceptive pill. Whereas the benefit of choice 2, no treatment, is you've got slightly better relative risk of breast cancer with no treatment. In other words, slightly lower, because it's something you don't want. So you can see here that there's a very good chance that you will reduce the risk of breast cancer, of pregnancy, but a slightly raised risk of breast cancer if you take the contraceptive pill. So that might be very much in favour of saying that you prefer pregnancy over breast cancer with those magnitudes. In example 2, we've got some obviously artificial numbers here, But if with contraceptive pill the relative risk of pregnancy is 0.5, and with no treatment the relative risk of breast cancer is 0.5 against contraceptive pill, so in other words, you're twice as likely to have breast cancer with taking the pill. Then with the same outcome indicators but with different magnitudes, then I think most people would say no treatment was better with over contraceptive pill. And so this is the idea that we've captured in our method, that what we get from either clinicians or patients is their preferences over outcomes and their magnitude. So returning to our example, we've got these 4 outcome indicators. And so we can capture these preferences in rules. So I give them here just in English, but we formalize them in a logical language in practice. So the first rule just says substantial reduction in pregnancy is more preferred to a modest reduction in risk of either breast cancer or DVT. So here we've got a clear preference. Then the second one says modest reduction in either risk of modest reduction in risk of ovarian cancer is equal or equally preferred to a modest reduction in either the risk of breast cancer or in the risk of DVT. And then finally, modest reduction in risk of ovarian cancer is less preferred to a modest reduction in both DVT and breast cancer, so those outcomes taken together. So going back to the example, the graph, what we see here is the following. So I used colours just to highlight what we're talking about, but it's really the directionality of the arrows that matter. So the argument's the same as what we saw before, but here what we see is that if you look on the left-hand side, we've got the argument at the top there involving E1. And this, excuse me, has that, just take over. Sorry.
So if we start with the argument E1 in the left-hand corner, you can see that there are 3 arrows that attack all of those other arguments. If you take the argument based on E2, which is in the middle left-hand side, you can see that it ties with arguments E3 and E4 in the top right and middle right, but is defeated by the argument in the bottom right-hand corner. And then the argument E1, E2 in the bottom left-hand corner defeats the arguments indicated by the red arrows on the right-hand side. So when you take this result, the important thing about this is when you form the argument graphs, you always get a symmetrical pattern of attacks. And what we do is we use preferences in order to break that symmetry and actually make some use of the evidence.
Okay. So then in addition, so this graph here just shows how we're viewing the evidence, what the evidence is telling us, and the preferences we have over what that evidence is offering us. But in addition, what we want to do is evaluate the quality of that evidence. So what we do is we bring in meta-arguments. So these are arguments that are counter-arguments to the yellow arguments we saw, the inductive arguments. And they highlight reasons based on weaknesses in the evidence. So we just got a few examples here. We could have flawed randomized clinical trials. We could have evidence that is not significant statistically. We could have trials with narrow patient classes and so on. So these are extra arguments we bring into the running example. So we can see that here. So it's the same data that we had before. So you can see the arguments there, the 6 arguments we had before. In addition, we've got this argument on the left. That's a meta-argument that's not statistically significant. So this is picking out the argument containing evidence E2, which, as you can see from the p-value, you might regard as not being statistically significant. So with this meta-argument, we've able to dialectically attack 2 of the arguments that we had in the graph. So the only argument that's remaining that's not been attacked is the argument just using evidence E1. So we've used the same colours as before. We've got the colour green. So the meta-argument is green, that means it's a winning argument, and the argument says the pill is better than no treatment based on evidence E1 is also a winning argument. And all the other arguments are attacked, so they're losing arguments. So the net result of this is that we can infer that contraceptive pill is better than no treatment. Here we've got another example. Maybe you'd like to talk about that.
So this is using actually some much more real-world data, looking about treatments for glaucoma. So again, we've got a pair of treatments here, which are sympathomimetics or beta blockers, and we note that we have different outcome indicators, which is what the different randomized trials have looked at. They've got different values in terms of the change in those outcome indicators, and whether we think that change is a good thing or a bad thing, and whether they're statistically significant. What's interesting about this example is, in fact, all of these studies are themselves meta-analyses. So because there have been so many trials done in glaucoma, each of these lines of evidence is itself a meta-analysis about the randomized trials. So you can see a similar pattern here. We've got 3 arguments down the left-hand side and 3 arguments down the right-hand side. You have a mutual pattern of attack, which we haven't shown. Then those mutual attacks are broken based on patient preferences. But the extra thing that we add here is we say, well, again, we're interested in statistical significance, and we note by looking at the table above that E18, E19 and E21 aren't statistically significant, and therefore any argument based on that evidence is attacked. And you can see therefore that as a result we end up with the 3 arguments on the right-hand side which suggest that beta blockers are better than sympathomimetics.
I'd just like to add that in this particular case, this meta-argument, and we can choose whatever meta-arguments we want to use in this process, as we can choose any preference criterion. Here, this is just saying that the indication, the evidence for that's for the indication is not statistically significant. So here, it's just in this, it's interesting because quite often when you have randomized clinical trials and even meta-analyses, the data is not so good for considering contraindications. So you might want to still consider and not attack evidence that's not statistically significant when you're considering contraindications. So here we're just attacking the evidence that involves indications. And so, for example, E21, which is not statistically significant, isn't attacked. So we've got an argument on the right-hand side that involves E21. It's not attacked. But as I say, you can choose whichever meta-arguments you want to use. And it's interesting to see different arguments being deployed. So a summary of our approach is the following in this flow diagram. So at the top in the middle, we've got the evidence coming in as an evidence table concerning treatments T1 and T2. We have the rules for generating the arguments and the meta-arguments. And so that generates the arguments. So that's the top orange box. Then we've got the preferences on outcomes and their magnitude, and that allows us to then to construct the argument graph. And from that, we then apply our dialectical criteria to decide whether treatment 1 is better than treatment 2, or treatment 1 is equal to treatment 2, or treatment 1 is inferior to treatment 2. So going back, we see here that we've got on the right-hand side, so sympathomimetics are inferior to beta blockers in this case. So beta blockers are better. In this example, we got that contraceptive pill is superior to no treatment. So what I'd like to do now, with the few moments I've got remaining, is, before I hand over to Matt, is to show you an example from taking evidence from a NICE guideline. So we've looked at a few NICE guidelines, taken the evidence, so this is just in the appendix from the guideline, and this concerns 5 treatments. And we consider each pair of treatments that have been compared and construct one of these argument graphs and decide which one is superior. So if you look at the evidence table, you can see where the the horizontal lines are. You can see we're breaking up the evidence according to which pair of treatments are being considered. And if you look at the outcome indicator, you can see that there's quite a wide variety of different kinds of outcome indicators that are considered. Some are for indications, some are for contraindications. So what we do is, for each of these pairs of treatments, is construct an argument graph. And so if you look at this graph here, which is a different kind of graph, it's called the superiority graph, which summarizes what we've found. So if you look prostaglandin analog and beta blockers, we constructed an argument graph, compared these treatments, and determined that prostaglandin analog was superior to beta blockers. In fact, when we constructed the argument graph here, we compared sympathomimetics with beta blockers, and you can see that's represented by the arrow going from beta blockers in the middle to sympathomimetics. So you can see the arrows showing that beta blockers is superior to sympathomimetics. So there's a line connecting each pair of treatments where there are studies comparing those treatments. And what we found with this study is that prostaglandin analogues were superior to all of the other possibilities. And this is consistent with the NICE guideline. We went on to do the same with a NICE hypertension guideline, and we found that the ACE inhibitor was superior to the alternatives, and this is indeed consistent with the NICE guideline. And then finally we applied it to the preeclampsia guideline that NICE did, and we found that aspirin was superior to the other treatments, which again is consistent with the NICE guideline. So my last slide is just saying that we've gone on to use our method in practice. So we applied our method to a large number of items of evidence, a large number of treatments, and produced a systematic review that was published in Lung Cancer last year.